Good afternoon, everyone, and thank you for joining us for this week's Facebook Town Hall. This is Katie Crystal, County Board Member, here with my colleague Christian Dorsey of the County Board as well. This week's discussion is coming as case numbers throughout the county and the state are climbing, with cooler weather in particular. So today we've asked Dr. Varghese, our Public Health Director, to take us on a more in-depth journey about how COVID is impacting Arlington and the public health strategy that's underway and that will be important for all of us to be aware of and participate in as we go about our day-to-day activities. Let me turn it over to Christian to welcome Dr. Varghese.
Well, thank you, Katie, and good afternoon to everyone. Dr. Varghese, who has been our principal person in responding to the pandemic, has also been working cooperatively throughout our region with other health directors and providing consultative advice to entities such as Arlington Public Schools when desired on the public health effects of this pandemic. And we are so thrilled that Dr. Varghese, first of all, is a part of our Arlington community and is able to support our response to the pandemic. And we are especially grateful that you have divined and are prepared to have our community understand, despite our ongoing fatigue in responding to COVID, to remember the important considerations from a public health perspective, where we are in terms of this virus's trajectory and what is to come next. So without further ado, you have the floor for an extended but very useful presentation, Dr. Ruben Varghese.
Thank you, Mr. Dorsey. Thank you, Ms. Crystal. Jennifer, could you put up the first slide? So I want to thank the board for the opportunity to discuss briefly the approach that we've been taking to pandemic management. Actually, and looking back, what I realized is we never got the real opportunity with all of the chaos of pandemic to actually tell people kind of like in one moment of what the whole package was. So I wanted to describe the framework or principles guiding pandemic management. And so on the slide that you're seeing, I wanted to remind people, first of all, of the basic epidemiologic principles public health uses with respect to communicable diseases, which form part of the base for pandemic management. So in the first portion, I want to remind people that public health in communicable disease thinks in terms of exposure leading to possible outcomes. And let me first, exposure to a germ leads to disease outcomes. And so the possible outcomes along that blue line, if it gets to that point, no infection, there may not be enough viral load, but not enough spread, could be the reasons. Asymptomatic infection, symptomatic infection with short, medium, and long-term complications. And unfortunately, we're going to learn about those over time because obviously we've had no history with COVID. And the worst scenario would be symptomatic infection without recovery, which leads to death. So on the second portion, I've got exposure, outcome, and this dotted line with a big red X. Really what that's about, what are the mitigating factors we can do, the infection control and prevention strategies at the individual level that can help reduce the journey to those outcomes. So these are things I'm not going to belabor them as much as reminding you, we've talked about physical distancing when outside the home. The greater the distance, the less risk of exposure. Don't think that should come as a surprise. The further you are from someone's respiratory secretions, the better you are. And as a reminder, the CDC definition for a close contact uses a distance less than 6 feet, and I'll get to the concept of trade-offs a little bit later. You want to limit the time spent within 15 minutes of others to the greatest extent possible if you're going to be within 6 feet distances or less. And you may want, when you're going to places, consider what sort of mitigating strategies a facility or event is using. Are they requiring 6-foot distances, masking, and the like? Then we go on to face coverings or greater when outside the home, when you may not be able to keep physical distance. And just in case, you should still cover your cough with your sleeve or a tissue if you sneeze or cough, because even though you've got that face covering in front of you, it's not hermetically sealed. So we're just trying to prevent even more virus from escaping. Obviously staying home if sick, washing your hands with soap and water, and things like increasing the air circulation. So if you first of all, making sure you have a properly maintained HVAC system, because if you don't, you're not going to have the proper air circulation. You can also consider increasing the air exchanges for your current HVAC system. And finally, cleaning and disinfecting services. That combination of activities are the way that there's a layered approach to preventing outcomes from happening. So that's one of the things you have to realize. It's just like the human body has layers to protect itself, all the way from skin to the antibodies in the blood system. These are a layered approach. Doing this together really provides you the most protection against exposure. Next slide. So before I get into the actual pandemic itself, we've seen this before, prior to COVID and even with COVID. Sometimes people confuse exposure risk versus complication risk. So I just want to make sure that I put everyone on the same playing field, at least how we're thinking about it. First of all, everyone is at risk for becoming ill from COVID. There is no natural immunity we are aware of. Who is at greater exposure risk from COVID? Persons living in congregate settings who are unable to manage their own activities of daily living, that they're dependent on others for services, i.e. they're unable to maintain 6 foot distances for their own care. So a person in a long-term care facility, someone who needs help with bathing or clothing or feeding, is going to be in closer contact with another person. Essential workers, those who cannot stay at home and must be customer-facing in their duties the majority of their workday without PPE, the personal protective equipment, and they're working within 6 foot distances of customers and staff. So who is at greater risk for COVID complications after COVID-19 exposure? The typical recommendation is those 65 and older at risk, but the CDC clearly also wants to remind people, among adults, the risk for severe illness from COVID-19 increases with age. So a 20-year-old is not going to have the same risk as a 65-year-old, but a 30-year-old will have a higher risk than a 20-year-old. That's the population statistic. And then those with chronic medical conditions, including lung disease, asthma, heart disease, and the others listed here. And the point I want to make is individuals have both greater exposure risk and greater complication risk are at the greatest risk. And so that's why we've seen in the long-term care facilities, you had people who could not manage their activities of daily living, so they were at greater exposure risk, and they're often have chronic medical conditions, and if they're of advanced age, wow, that puts a lot of things together when you're exposed to viruses that get trapped in the space. Next slide. So this is a curve that I think some of you have seen before, but I want to go through as a reminder. The big purple curve is an uncontrolled outbreak without intervention. And that pandemic is, I often have used the term, it's an outbreak on steroids. And what we're really trying to do is, remember, was to flatten the curve. But I want to remind people, flattening the curve was done to reduce the peak number of cases and related demands on hospitals and infrastructure, not to get to preventing infections at all costs. It was so that we can function well and so that there's a healthcare system available to actually treat people as they need to. So phrased another way, flattening the curve assumes we are prepared to live with a certain level of virus in our community. Once you flatten the curve to whatever level is acceptable by the community, you're making decisions about the trade-offs with other priorities. When you flatten the curve, you're giving time until a vaccine or treatments that are effective to become available, which means you have to decide to learn to live with a virus. Otherwise, when we recognize that if we prioritize almost exclusively infection control, that means you aren't considering other societal priorities, which really also are public health priorities, and there will be other health impacts on populations. For example, without a robust economy, many populations will be affected by a poor economy, which has health effects. Without education, many populations will be affected by poor educational attainment, which has health effects. So what the balance is for that is a policy decision for each organization that makes policy decisions affecting the public's health. Next slide. So this is a slide we've used both in Destination 2017 and in Destination 2027. And so speaking of public health, I want to remind you all that these organizations on the slide, which we've called the Arlington Local Public Health System, and this applies to more than just Arlington. We stole this slide from the National Association of City and County Health Officials, and there are many more not listed, are responsible for the policy decisions which cause the public's health to emerge from those decisions, both for the organization's customer base and their staff, and for the organizations which they touch or depend on. Phrased differently, this conglomeration of organizations in our society and elsewhere contributes a component each to the larger health of the public. So with the COVID community transmission and flattening curves, it's a policy question up to the various organizations for their own organizations and for their responsibilities for the communities they serve. What is the right balance between infection control and economic and social priorities, which all have public health benefits and costs? And I want to remind folks that prior to pandemic, we cannot say that our system or any system collective policy decision led to perfect health for all populations. Our Destination 2027 work showed there was a decade of difference in life expectancy in a mile distance between census tracts in Arlington pre-COVID. So it means there were good and some bad health outcomes and others for before 2020 and COVID. What COVID has done, I think as everyone knows, has disturbed the existing system, and the system is trying to recover organization by organization just as much as individuals and families to this disruption, and each organization is trying to learn how to respond and regain resilience with this disruptive influence still present and likely to be present for the next year to 18 months. So how do we learn to live with the virus and perform our pre-COVID purposes and services? Each organization and its leadership has a policy decision-making authority to decide how to resume their pre-COVID public health responsibilities with a need to mitigate COVID-19 exposure. So unless our collective goal is to prevent infection at all costs, our community at the individual level, household level, and organizations have to come to terms with living with the virus just as we as individuals and families are coming to terms with living with the virus. So how does your organization recalibrate services in the context of living with a virus at the flattened level? Next slide. Okay, so this is a slide that we've adapted from Prevent Epidemics. What I wanted to talk to you about are the various elements. So at the top, you see a pandemic curve from no cases, sporadic cases, clusters of cases, local transmission, wide transmission, and declining transmission. And the red circle there is to show where we are in kind of this scheme. And so the way we think about things in public health are the disease control aspects, providing infection control and prevention guidance to various organizations, testing widely, and notice there's a gap at the height of any peak. Because at that point, it sometimes may be so much disease that we're not going to be able to keep up with it. It's just the reality, and we don't want to hide that fact. We were able, and obviously when this first started, testing was at a premium because the nation was behind. We, of course, then isolate infected people, and we provide social, economic, and emotional support for the cases, and trace and quarantine contacts, and also provide social, economic, and emotional support for those cases. There's a category called non-pharmaceutical interventions, or NPIs. So these are the things that we do. Fancy way of saying we don't have treatments or vaccines to these things. These are behaviors. So the everyday personal NPIs, we still value washing hands, covering coughs, staying home when ill. The environmental NPIs, cleaning surfaces and increasing ventilation, and we've provided guidance from CDC, ASHRAE, and others. The new personal NPIs, quarantining when asymptomatic as a contact, and isolating when COVID positive symptomatic. The reason why it's a little different from staying home when ill, we're actually getting involved with it and telling people staying home when ill is usually a personal decision, whereas quarantine and isolation are recommendations that come from the health department. New personal NPIs, we've now started getting used to wearing face coverings out in public and physical distancing when out of the home. And then there can be societal decisions for NPIs, the distancing orders and closures. Sometimes these are state mandated, otherwise they're often organization specific decisions. I'm going to skip to pharmaceutical interventions next at the bottom. That's where you talk about treatments when you're in the hospital. There are no outpatient treatments, but there has been increasing evidence of what they can do to help mitigate some of the complications if you need to be hospitalized. And obviously, vaccines are an important thing that we're hoping will work. There's a lot of activity with vaccines being produced. The earliest we're anticipating vaccines to be available sometime between January and April, and that would be in a limited supply for folks in the highest risk categories or healthcare systems that need to be kept open. So going back to the supporting society piece, I want to make sure that people realize it may look like it's a small component of the activities here, but this is as political as I'm going to get. It's like the Electoral College map. You shouldn't look at it as the size of a state is how big or small its importance is. This is really a very important thing that this community, government, nonprofits, and the private sector have all been involved with. Making sure, how can we deliver essential health services? So for example, maintaining vaccination, providing for maternal and child health, behavioral health, and care of chronic services or conditions. Essential societal services. How do we support continued social and economic activity, including learning, emergency services, and essential activities? This community has been working on that, including the government. And then addressing ongoing needs, including supply chain management. At the beginning, PPE was difficult to find and testing. PPE still isn't a stable system for Arlington or the rest of the nation or the world because of our interconnected economies, and with a global pandemic, supplies are limited. And we've been putting in things for, say, telemedicine and teleeducation and health equity. These are all of the things that, in a sense, the framework, and it's not just the health department that's doing it, it's that whole system that is coming together to try to provide these activities. So if you could go to the next slide. This is the final slide, folks. I wanted to give a different pandemic curve than what you all have been seeing. And this is literally from our website for the dashboard. And it's the overall weekly COVID-19 cases by symptom onset date, okay? And you'll see that I actually used the computer to draw a black squiggly line to show the curve. And so one of the things I want to show you is, yeah, we did have that peak in the curve, and then at about middle June was when the cases went probably the furthest down, and that was at the end of the governor's executive orders for the stay-at-home orders. And so obviously you could see the curve was being flattened. What you can see here is that as we've allowed more people to congregate under the governor's executive orders to 250 people at most or less, we've seen a rise in cases. That doesn't mean we have hit a spike. This may be our flattened curve, okay? What I've done is, and I'll have staff probably help me in the future, that they talked last night. Here we're looking at, you could have the line at the top in red. We didn't exceed our hospital capacity then. I don't recommend that we allow ourselves to get to cases that high, because then we don't have the surge capacity to respond there. But it may not be realistic to go as low as the other red line at the bottom. And so it's a public policy decision about what level, what's the right horizontal flatten the curve level that we can live with the virus till we get the vaccine, so that we can go on with the other things in our community. So I am going to end that there. And so I just wanted to give that sort of overview, because we've never really had that conversation about living with the virus. So you can stop that presentation if you'd like, Jennifer.
Thank you much, Dr. Varghese. We very much appreciate that presentation. We can probably begin this conversation with some of the questions that are in the chat and that have come to us via text, and a lot of confusion around testing and the availability of testing, what's happened with the arc of testing in Arlington. So just to, again, orient people with where we are today, can you speak about the level of testing that is available in the county, in what forms and in what manner, and how people should look at the availability now compared to during the early days of the pandemic.
Okay. Jennifer, if it's possible, I would ask you to pull up the dashboard with the testing site information, because I think we probably should let everyone actually, if we can spend a few minutes actually going through it so that people actually can see where the information is and how to find out about where the sites are in case there's any confusion.
Yep, no problem. Hold on, Ruben.
Okay. Because on it will show where we know of places in Arlington, also a PDF of home testing kit options. And obviously you can go to the other health departments in the area and see where they have public testing sites that aren't necessarily county run, but where resources can be adopted.
Okay, here. See if I can, right. So this is our main COVID page, just if people who are looking for this later. And here's the dashboard. And Ruben, you wanted to go to which area?
To the Get Tested for COVID-19.
There we go.
So on that site, literally there is a PDF of documenting all the sites we are currently aware of in Arlington specific that provide testing opportunities. 2 of those are run by the county. The Arlington Mill Community Center site is for those, it's done in partnership with the Arlington Free Clinic, and it's for our health equity efforts for those who are underinsured or uninsured. They register with the Free Clinic to get an appointment to be able to get tested at the Arlington Mill site. We still maintain the drive-through collection site at the North Quincy Street site, and you need a referral for that. But we wanted to make sure there's a listing here that tells you the name, the phone number, the website and hours of the facility, the test type that's provided, the eligibility requirements that are provided, that are required, the testing, if an appointment is needed, if language interpreters are available, do they accept uninsured patients, and they give cost information. So wanted to show that first. And then Jennifer, if you scroll down on the Get Tested portion, there should be a PDF to the home testing. So if you could pull that up. This is a list that's maintained by the staff of, you can actually have mail order kits, and 2 of us on this call I know have actually used them, where it can actually be sent at home, and similar things, the eligibility requirements after the name of the company, the collection method, is it a nasal swab, saliva, both are possible in this list. Their advertised wait times, the costs associated, and if insurance covers that. And this information is also in other languages as well as the previous information as well. So there's that portion. It really is a market may bear situation, and we've been doing between 3,000 and 4,000 tests in the Arlington area, even though not all of them are being conducted in Arlington. And I was going to see if Dr. Miller from our Office of Emergency Management had anything to add on this.
We're seeing availability of testing continuing to increase, and we've got an average of 500 to 550 tests being reported to the Virginia Department of Health on a daily basis. So as you can check that status. It's a rolling 7-day average. It's on the Virginia Department of Health website. And since I just got the updated numbers, since the beginning of the pandemic, 74,502 tests. Those are the PCR tests alone conducted in Arlington County. 14,041 It's probably a little bit higher than that now, but 14,041 of those PCR tests conducted at Arlington County sponsored facilities, including the North Quincy drive-through sample collection, Arlington Mill, and our pop-up testing events, just to give everybody updated numbers.
And Dr. Miller, for context, at the earlier days of the pandemic, I seem to recall that we were somehow having about 200, 250 tests a day coming from Arlington, so roughly double the capacity from the early days.
Roughly so, yeah. And we continue to grow as more private providers bring testing capacity online.
Katie, you want to stay with public health, or should we shift to a source of a great number of questions today?
I think we should. I think we can certainly see that probably about 95% of the questions we're seeing are ones about when public schools will reopen. Let me begin by saying that I completely understand that there are members of our community who are looking to the county board to provide a different answer on school reopening than the one they've gotten from APS to date. Christian and I are both parents of young children, Christian with school-age children, and I think we can really resonate with that frustration. It is also the code of Virginia that school boards are vested with the authority to manage public schools. It's also, I think, a good practice that school boards are vested with the ability to manage schools and not county boards, because it keeps accountability with the folks who have the ability to make that decision. And it gives them the ability to make decisions in partnership with the superintendent that have to do with the students they serve as well as their workforce, groups of people that the county board does not have as much insight into, in particular their workforce. I'm sorry, but we're not here to give you a different answer than the one you've gotten from Superintendent Duran and the school board to date. That said, we have some excellent questions about what the county board is doing to make ourselves aware of and to support the APS superintendent and school board in making these incredibly important decisions about getting our students back to school as quickly and also as safely as possible. And so a brief word, and then I'll invite Dr. Varghese to share anything else that he'd like to. Most importantly, our county public health staff has been providing detailed information, conversation, and guidance on everything you've just seen today in this presentation on, I think, a multiple times weekly basis. Specific guidance on specific practices like air quality and face coverings like some have asked about. And the county board has appropriated $12 million, about $10 million of that from CARES money, and more money from other sources to pay for critical needs to not only support students who are out of school, like that extensive internet connectivity program described in the materials shared in the chat, but also on things like personal protective equipment and public health staffing and other pandemic-related services. I think that I speak for all of us on the county board when I say that we are in regular contact with the school board. We are committed to assisting schools in its pandemic response in any way that we can, and to support enabling students and teachers to get back to in-person instruction as safely as possible. So while I cannot give you a different answer on the decisions about when schools will reopen and in what phases than the ones that you've heard from Dr. Duran and the school board, I hope that information gives you some insight into the fact that this is a huge priority for us and that we are working to support this goal however we can. Dr. Varghese, would you like to add or clarify anything about the work that you're doing to inform and consult with the public schools?
Sure. Great question. First of all, just for the day-to-day operations when they do come back into place, we have our school health bureau, and we've been working with Arlington Public Schools to create an environment that if children need their medications or first aid or become sick in the school, what the schools should do when in-person instruction return. So they set up they've got plans for isolation rooms that would keep the children who are sick. We're going to presume everyone has some sort of communicable disease so that we don't want them to be going to the school health clinic where children who need their care plans managed with medications during the day are kept separated from each. If a child has an injury, we wouldn't consider that to be related to COVID or any other communicable disease. That's where students would go for care as well, so that we can make sure that the children who are sick stay together appropriately and that families can pick them up as soon as possible to take them home. We provide make sure that the school system has the CDC and Virginia Department of Health guidance on schools. One of the things I think people get confused is that there's a specific health metric that determines whether things open or close. And that was one of the things that I wanted to point out in my presentation, in a sense. It's really going to be up to the community within the school system to say what they're comfortable with. And it's a collective decision, in a sense. So by way of analogy, if I was your doctor and any one of you was my patient, and God forbid it was something like a cancer diagnosis, I would end up telling you, after we knew what it was, what your options are. And I'm hypothetically saying it may be cancer chemotherapy, radiation, immunotherapy, a combination of those things, or doing nothing. And telling you about the pros and cons and understanding what your values are. It's going to be ultimately up to the individual patient to decide what they're comfortable with of which of those options, because I don't have the expertise to know what you value, what's ultimately the decision on quality of life and how many side effects you may be willing to tolerate. So likewise, we give the information about there are places that may be quite comfortable with opening schools if this, God forbid, happened again, and we got to the levels in March or April. If the community felt that they could do all of the appropriate behaviors in school to reduce the exposure risk, they have the right to do that, unless the governor were to say closure is not, opening is not allowed. So that is the balancing act that people have to think about. There are populations, as you said, there are the student populations and the adult populations, and they are having to figure out not only the educational health priorities, but their population health priorities to each of those groups as well.
Thanks, Dr. Varghese. That was a grim, but I think really illustrative example. And any one of us who's had the opportunity to talk to a doctor and desperately wanted an up or down answer, I think that really resonates, the fact that it's a choice of values and other priorities as well. So thank you. And Christian, let me turn over to you for the next questions, or if you wanted to weigh in on the same.
Yeah, I'll weigh in and then transfer us to, I think, an extension of this conversation. So, as we have tried to relate to our community, and Katie, I think you just did a terrific job in, explaining the framing for this. We want to be very clear that if APS were to decide to open schools, we believe that we've provided the resources necessary for them to do that. And that's primarily in the form of the cash assistance that Ms. Crystal talked about, to ensure that they have the not only personal protective equipment, but they have the staff to do everything from administer pre-boarding bus or pre-entering school checks. So while APS has certainly been hit hard with revenue loss and has a budget gap that they're working to fill, in terms of providing the upfront expenses to ensure that there can be a safe return to school, we believe that we've met those fiscal needs. And if we can put up the slide, which will address the specificity of the cash transfer to schools, as well as other questions about where the county has devoted its CARES Act funding. Slide 6 of the presentation that I believe is queued up.
Give me just a sec, working on it. Let's see. Sorry, I think we've got the wrong window. Let me try again here.
No worries, no worries.
Let's see.
And while we're waiting for this to queue up, another dimension of this question in terms of support for schools comes in the purview of testing. And Dr. Varghese, do you have perspectives on what our community should think about when it comes to the availability of testing, whether they be rapid testing for students and faculty as part of any reopening strategy?
Thank you. There's been no official recommendation, or let me try that, from the CDC perspective, which I agree with. Routine testing on the scale that I think some people are expecting, like daily or weekly, has not been recommended. What we would encourage people to do is, obviously, if they become symptomatic, we have testing resources in our community and have them avail themselves to that. And while they're getting tested or they're ill to stay at home and work with their physician to be able to get the care they need and to quarantine or isolate as necessary. And that would be what we would continue to recommend. And there's an actual algorithm that the Virginia Department of Health has actually put together that we have shared with the school system. And it's available to parents online so that they understand how testing has a role. But I think some people believe a negative test is the key to coming back to school. And actually, that's not the case, because a negative test only tells you for that day you weren't able to detect the virus. That doesn't mean you couldn't potentially incubate the virus during that time frame. And if you were actually a contact of a case, we would still say you need to be quarantined at home. And that's why it's good that the school system has the ability to put people on virtual education, as I understand, while they're at home. But more of those details would have to come from the school system.
Thank you, Dr. Varghese. And I see that we now have the slide up, which addresses the questions not only about funding for schools, but there have also been some other questions about where else resources have gone in responding to the pandemic. Ms. Crystal, do you want to have any commentary on this, or does it suffice to show this to our public to address that specific need?
That's a great question. So I think what is maybe going to be most helpful for those who are really interested, not only in the sort of broad categories, but really the specifics. And I think one of the questions we got and exhorted us to be specific. I'd really commend to your attention a link that I think we can share on the Facebook chat, or that you can navigate to by going to arlingtonva.us, clicking on the county board page, scrolling down to where you can find a joint work session, video of a joint work session with the Arlington Public Schools. And that's where you'll find in that video presentations by our managers and Department of Management and Finance staff, really explaining specifically, when we say we're spending $100,000 or a total of $1.3 million on quarantine and isolation housing, who's receiving that? Who's availing themselves of that quarantine housing? Excuse me, further conversation, for example, about I think at this point, threefold, maybe fourfold strategy to get that 98% of APS kids connected to their online classes. So if you're looking for that specificity, that's where you could find it in the videos from those work sessions.
And I believe the direct link to this presentation has also been made available in the Facebook Live chat as well. So broad strokes, there have been roughly $40 million in additional resources brought to fight COVID, and the allocations have gone broadly to meet the needs of the pandemic, but a substantial portion have gone to public schools to provide those resources to allow them to reopen when they determine that they would like to. All right.
Got a couple of other questions teed up. Yeah. One that I think is really interesting and I hope will be salient in the near future: vaccine planning. I know that the state, this Dr. Varghese is probably a question for you. I know that the state with whom you work closely has developed a strategic plan for the rollout of a vaccine once one is available and safe. Could you give us some insights into what the strategy is around a vaccine rollout once one is available, either in Arlington, in the region, in the state, or whatever other unit of government will be helping us stay aligned?
Sure, great question. So our rollout plan is related to when we get, obviously, when the vaccine is likely to, how much vaccine we're going to get, what the priority groups are, and who's available in the community in addition to government to vaccinate. So let me see if I can take each of those elements. So as I said in, I think, my earlier presentation, vaccine is unlikely to arrive in any significant scale between January and April. And even then, it's going to be a limited supply because it's across the nation. And, there are other actors in the world who want the same vaccine. So the communities are going to have to realize that there are going to be priority groups recommended by CDC for the vaccine. And the typical groups would be healthcare workers, especially those in hospitals and emergency medical services. And if there was enough supply, they would probably be my gut instinct is that they would say, try to give it to older individuals, especially those in long-term care facilities. And so that will be the first set. And then basically based on kind of that exposure risk categories and complications, as doses increase, it will become made more available. One of the things that people need to be aware of is the vaccine will most of the vaccines will require 2 doses and separated by 2 to 4 weeks. So that's going to be part of the complicating factors of getting people vaccinated. And we're not necessarily going to be saving doses for the second vaccine for one person. Rather, we'd be giving more people the first dose and then having to get a second dose in as we can. That will probably not make people all that happy, but we are going to have to be as fair as we can. And in that respect, then it's going to be, how will the private sector and the public sector interact? We are trying to, we've put out the notifications to providers through the state of whether they're interested in providing vaccine, and then we're also ramping up our efforts to deliver vaccine as we did during H1N1, for those who remember when we were at the 3033 Wilson Boulevard site. We would be providing vaccines in government buildings, and we're trying to have plans to be able to vaccinate up to 35% of the population, because that's what they believe would be the likely interest in the vaccine, because not everyone's going to be eager to take a vaccine. There's always going to be vaccine hesitancy, but 35,000 people, or 35% of a population of adults of probably 150, 180,000, that's a sizable number to have to work with. So those are going to be, the devil will be in the details. Where will we be able to do it? I suspect some of the vaccine that we would provide would be at our Sequoia facility, and then we'd have to see where else in the community we would provide it and how would we allocate those resources. So they're in broad terms, Ms. Crystal, in that sense, and that's why the devil's in the details, because we don't know where the sites will be yet, because we need to know what buildings are available. Our previous things would always be in schools. That may not be the right place to deliver it. And so where would we do it? And then be able to have 6-foot distances. What people have forgotten when we do this, it's still going to be virus out there. So we have to be able to do it at 6-foot distances with masking. And even after vaccination, you're going to still need to do 6-foot distancing and masking, because we don't know how effective a vaccine will be without some passage of time.
Thank you. Could you say just a little more about that 35% number? Is that's a rule of thumb in public health, or something that we'll see deployed elsewhere, that's a critical threshold for vaccination?
Well, it's a good question. It's not necessarily that it's a critical threshold. It's what they're estimating would be the likely uptake for the population. We want to be wrong and hope that more people will want it, but they're saying plan for 35%. It's just, remember, everyone right now would say they want a vaccine, but that's also based on they're tired of what's happening now, and everyone wants the rare commodity. But what we've discovered very quickly is, in any effort, once it seems like it's available, the desire for it drops more incredibly. And then people, of course, you've got the people who are hesitant on a number of occasions for a number of reasons. There may be people who are afraid of government. There are people who are hesitant about vaccine in general. So we don't always assume that. So we'll be happy and be prepared for continuing to vaccinate beyond 35% of the population. But we won't be able to vaccinate 100% of the population in one day. As you know, so people are going to have to be, their expectations have to be managed. Priority groups would be done. The state has been working with, and the federal government has been working with groups like CVS and Walgreens to partner with long-term care facilities. Hopefully they'll say yes to just go in and provide those vaccines directly. That would be a way to protect those individuals first and quickly, and as we then not have to try to do those clinics as well as for the community.
Thank you. That was really helpful. Let me turn to you, Christian, for the next question.
Sure. Dr. Varghese, I think I could answer this, but I would prefer if you did. Some people are looking specifically at colder weather and circumstances that they encounter, such as walking in areas where people are congregating outdoors to smoke, and wondering if those provide an increased risk of virus hanging in the air that they could be exposed to, and if you have any precautions that you advise people take should they encounter those situations. And then we have some other questions about the ability to enforce public behavior, but I'd like for you to start there.
Okay. I prefer the first question to the second question, but anyway. Like anything else, obviously, the general principles are if you see people congregating, you should move further away. That is the basic concept, whether it's warm weather, cold weather. We're still recommending that people don't congregate with others that are not part of their bubble, that they should maintain 6-foot distances, and when they cannot, use cloth face coverings as you pass by, and so on. Being outside is safer than being inside in that respect, because dilution is the solution to pollution. So that's where I'm going to leave it. Obviously, if you've got people congregating, yes, they could actually have more virus being shared and spread there. So I would just move further away. I am absolutely, I've forgotten what the first question is, but I know I didn't want to answer it. So if you can ask me it again, that would be great.
Well, you know, with the next one, I was joking. I'm not going to ask you to answer that because that's really a question for Ms. Crystal and myself. And it's something that we have spent, as you may imagine, a fair amount of time thinking about how to force compliance of the guidance that Dr. Varghese has so ably provided us and the community. So people note observations of people not distancing, people not wearing masks, and wondering if there are enforcement mechanisms that we can employ. As you may recall, during the summer, the county board did try to implement a requirement to enforce physical distancing on sidewalks around noted areas of congregation. We don't need to rehash that long public debate. You can look at it. But we found it ineffective ultimately at the end of the day, enforcing the compliance that was necessary. It's not that we've diminished any interest in seeing that people do follow the guidance, but we found that at least in that case, enforcement didn't provide a workable tool. What it has meant, it's required us to very much try to engage as many people in our public as possible so that they understand the guidance and hopefully compelling them to apply it in their lives. That is by no means universally effective. So we're dealing with a case where we found forcing compliance was not very effective at all, and we have to accept that compelling compliance doesn't have any leakages, and we're really looking for ways in which to get everyone to do what's needed for us to get through this as quickly as possible.
Yeah, I think that's right. And I think it may be also bear noting, because I know seeing folks crowded in restaurants or crowded waiting for restaurants has been a source of tremendous frustration for a lot of people in our community. We've seen some comments to that effect today. What is true is that the governor's mask mandate does apply to indoor areas. And that is something that our public health, in fact, we have sort of interdepartmental team, including public health, police, building code, and others visiting these restaurants. I say restaurants rather than bars. As you all may know, it's sort of a quirk of Virginia code that we don't have a separate classification of bars. So that sometimes adds a little bit of a wrinkle. Any shutting down of restaurants applies equally to Joe's Pizza or Bob and Edith's Diner as it might apply to a place that is notable for its nightlife. Nevertheless, I think we have found quite a bit of success using these interdepartmental teams to not only mandate or enforce the compliance for the mask mandate, but also to proactively work with the bar or the restaurant owners and their staff to help them put up bollards, for example, so that the lines are better spaced out, to ensure that they can tightly manage the significantly reduced capacity inside the establishment, which is part of the governor's orders. I think in a case or two to shut that restaurant down if they're in significant and repeated violation of those orders. So there are teams that are out, that are underway. We think there is some progress there, although I understand that it doesn't matter if there's been holistic progress. If you're seeing one bar or one restaurant packed like sardines, as Ms. Sanders noted in the comments, that's infuriating, especially when there are other ways in which daily life has not resumed. And so I believe that we still have our website for people to file complaints about establishments where they're seeing lack of compliance with the mask mandate, social distancing, occupancy ceilings, and so forth. And so I would encourage you to use that website. I think we can share it in the chat. If there's one that you think our interdepartmental team has missed, flagging it to us can help us ensure that a visit is paid.
You know, Dr. Varghese, there's another question, or maybe you don't need to address this, but randomized rapid testing, which is a tool that has been used in other jurisdictions to provide a greater level of confidence, particularly as it relates to the confidence of workers to return to an environment where they may be mixed with other people who can transmit virus. Has this been a part of the conversation with Arlington Public Schools? Do you know if this is a tool that may help them in creating confidence among teachers to return to the workplace, which we know is a metric that they're using to determine reopening readiness?
It has not been part of the discussion, and happy to look to see if there's any official recommendations on that. The real issue, though, that we found, which I think the question actually belies that people keep looking to, that testing is a magic bullet. What we've actually seen in most circumstances is it's actually the behaviors of adults that we've seen it in hospitals, we've seen it in even in the government work sites and so on. With clients, they behave one way, and then with each other, they get close together. And it's not suddenly that the people you work with are living together in the same bubble. So you cannot actually get close to each other regardless of what the testing shows. And so that is one of the things I think we've all started learning behavior change as we go out into the community. I remember how much more nervous I was probably during the pandemic. Maybe I knew too much, but still, and now I'm more comfortable and know exactly what to do in limiting my times and getting efficiently through the grocery store and so on. So likewise, we need people in all settings, in all work settings, to think in those same terms as if you're going to the grocery store. How are you limiting your time with each other, keeping the distances and so on? That's still going to be the best way to actually ensure your safe return, because viruses aren't leaping on a routine basis beyond 6 feet. And that's what we've got to encourage people. It's actually been mostly adult-to-adult transmission that is the biggest concern with this virus.
Katie, do you have anything else queued up?
Well, just a couple of questions that I think I may be able to speak to briefly, although I'd certainly invite you or Dr. Varghese to weigh in. A few questions about the geography and the demographics of outbreaks. I don't know that it's accurate to say that we have outbreaks or sort of super spreader events in Arlington, but for those who are interested in learning the way this virus is affecting different areas of our community, be that zip code or demographic, you can find all of those on the county's COVID dashboard. I think we can share that link in the chat. I don't want to make our team have to pull something else up. I know that's been a little bit of a challenge today, but that's been really important to us from an understanding and equity perspective, as well as focusing our education, testing, and other public health outreach events. So you can find all of that on the COVID dashboard. Good question as well about why libraries are not reopened for browsing. I imagine people on this chat or watching this chat has seen the library director's note as of October 22nd. The short answer is, we are in the middle of an economic crisis as well as a pandemic. There have been desperate efforts to try to mitigate the impact on Arlington's budget, and certainly to keep our deeply valued county employees in their roles. But some of the contractors and part-time employees with libraries have not been able to be retained. And so that means that they're operating on a more short-staffed basis. I know that the library's director, along with her team, has made the decision that to best and most equitably serve all of the Arlington community, there should be a robust holds fulfillment opportunity opportunity rather than reopening one branch or another. And so you'll see that at Central Library. I know, especially for younger people, that desire to browse is great, or is significant, I should say. And I think we're all pretty disappointed that that's not something we've been able to facilitate at this time. Please do watch this space. I think we're all hoping the budget reality may turn the corner and we could see not only the maintenance of that safe holds fulfillment and pickup opportunity at Central Library, but maybe some limited browsing at the branches in the days to come. I don't know if there's anything you would add, Christian or Dr. Varghese, to the libraries piece.
The near future would be my preference, certainly, and we do have plans to think about geographically opening up other branches in some limited capacity, which hopefully will come to the plans are complete, but hopefully we will see implementation on that sooner rather than later. So, I understand where people are coming from, and it's especially disappointing when you see other jurisdictions who have figured out how to do it, and you wonder why your jurisdiction has not. There are some definite resource issues there, but by no means do I believe that this is beyond our capacity to solve.
Right, I think that's on a more optimistic note. And I see that we are coming to time at 1:30. I think it may make sense to end by once again recommending folks to spend some time with that COVID dashboard, not only to find the demographic and geographic information I was mentioning, but also that is the landing page for all of our materials, all of our answers for not only how you can protect yourself and your families, say this Halloween or this upcoming Thanksgiving, but also for information about all of our facilities reopening or hours plans, testing, where to find testing throughout the community, and any other news that we have to share. That website is a great way to do it. Christian, any concluding thoughts?
Sure. I just, again, want to voice what I'm hearing from many people, and that is a fatigue with COVID as it manifests for themselves in their own lives. And I think we all understand that. And no more is this more acute than it is for parents who would like to have their children in classrooms. I have 2 children in schools, and I would much prefer that they be in a learning community with other peers, with live instruction from a teacher. That is absolutely my desire for them now. It was my desire for them a couple of months ago. That said, we are where we are because of a pandemic that everyone is doing their best to try and manage for all of the considerations that they have before them, whether it is the availability of facilities, the availability of staffing, and the ability to confidently protect the public health while delivering their mission. So hopefully we can all continue to pull together and work towards helping everyone fulfill their mission effectively. And certainly that is the responsibility that I think we on the county board take with public schools. First and foremost is ensuring that when they are ready to make the decision to return to school, they can do so with the ability to implement all of the public health guidance that they have decided is important, and that they have the resources to keep our community safe. I think we are there. What is left for people is what happens with bringing kids to school, but we do understand the enormous toll and cost this may present for many families in our community. And we certainly think it is important for us to all work together to resolve as quickly as possible, understanding fully, though, we have different responsibilities in making that happen. So thanks, everybody, for your participation on Facebook. Thank you for your texted questions in advance and during this conversation. Ms. Crystal, my first opportunity to share this venue with you, so thank you for the opportunity, and thanks, everyone.